Let us come to E2 monitoring. Prior to going for E2 monitoring for IVF patient, the basic test which usually come to our lab is day 2 or day 3 profile. So usually we come across FSH, LH and E2 levels. So what is clinical significance of this test and how do you go about it? Like, is it protocol dependent, or which various protocols do you follow for that?
Uh, Basically, what we suggest our patients, first of all, we as a clinician follow that we want to know the FSH, LH values within first 48 hours of onset of menstruation. So we don't tell them according to the day. It is the start of menstrual cycle. Whatever time of the day, night they see, within first 48 hours, I want to see the ratio of FSH and LH. I do not want to see whether they lie into the range or no. I want to see what is LH standing at what level of that FSH, and it's my kind request if we can add on that as a ratio. As we see in the other reports that it is very important for a clinician to understand, even if they read, they don't know LH has to be less than half of that FSH, and the normal value of LH is 2.5. So if any value they see, okay, fine, it is lesser than half, they will accept it. But it is not correct, and that is why so many people are remaining as a infertile couples in spite of seeing 5-10 doctors. So I think this is a good chance for me to tell you, to teach the clinicians that please see this ratio. And your LH is rising out of its range, and treat and suppress that LH. So this is one opportunity I'm taking. Secondly, E2 we will see at the time of checking this onset of menses, because I have to see before starting the IVF cycle that the E2 value has come down to the basic, that is less than 100, so that I can start with the stimulation for that patient. So yes, it is very, very important, and as a protocol within first 48 hours. So if any patient is telling me on Saturday afternoon 2 o'clock, I am seeing my menses, I will call her right away. This is your first day, I'll take your sample. I'll not send her on Monday to give the sample. So by then her FSH will rise.
So you prefer day 1 sample rather than day 3 sample?
Yes, I don't want that FSH to rise so that I get a wrong report that LH is less than half.
If there is any variation in FSH and LH ratio, then do you add anything on these days?
Yes, we definitely start the suppression in case we get a LH value as high. So I have to know that immediately, so that whether to start her cycle with the LH normal or to suppress her for 1 month and then start her cycle. That is my decision depending on this, whether to start IVF cycle or hold on, give a suppression, give us some depot injection or something, so that I can take care of this LH hormone, which will not interfere in my protocol.
And for this you don't need support of any other hormonal level?
No, these three are the very important things for me.
Yeah.
Dr. Patke, do you want to add something on this?
No, sir. Right at this point, no, nothing. I have to.
Yeah. Okay, so estradiol is involved. It is FSH, along with FSH LH, it is responsible for ovarian maturation and ovarian growth, ovarian follicle growth. The value of E2 is highest just prior to ovulation. This is important to know because there is serial monitoring of E2 levels in IVF cases to see the day and choose the time of ovum pickup or ovum retrieval. So these are various patients who have, one of the representative case of various patients samples which come to our lab. Here we can see on day 2 the value is 14, and then there is serial increase in these values. So my question is whether this rise is expected, is there any expected proportion of this rise, or is there any specific, it is protocol dependent?
it is definitely protocol dependent, but it will depend on the number of follicles what I'm seeing which are being selected. And definitely yes, we have to see that increasing rise depending on the number of follicles and their size. So how many dominant follicles they are expected to secrete around say 200 to 250 picogram of estrogen when they are dominating, and 14-15 millimeter size follicles would add on somewhere around 150 or 175. So accordingly I would see how many follicles are there on my sonography and how much estrogen is been seen on this side. So yes, it is sonography dependent finding.
Yeah. For this, you give certain medication for to increase the dose, to increase the level of E2. Which kind of medications do you give?
Those are either
Okay.
so gonadotropins or recombinant FSH injection. That depends on the patients, which patients will receive what injections.
Okay.
Yes.
So there is individual variation
In the selection of the injections, the type.
Okay, but on which findings and on which factor do you decide this? That this patient should go for FSH antagonist and GnRH antagonist.
This would be decided depending on her FSH-LH ratio. It is a polycystic patient or no. So if the patient is having her intrinsic LH value which is on a higher side, then we would go for the recombinant FSH injections. And if the patients are having very regular cycles with very regular LH values, then yes, we need to add on some little bit quantity of LH, and then it will be the GMH injection, the gonadotropin injections actually.
Yeah, this is another case which shows that the levels are not, though these are increasing, this is not a significant increase in the value. So what is inference in such cases?
This is one of the very important finding, and this would give me a suspicion whether her suppressed LH is rising now, whether her follicles have got stagnant and they are not releasing more estrogen. But here I would also correlate it clinically on the sonography, whether her endometrium is also growing or it's not growing. Endometrium gets stagnated, the follicles get stagnated, they will not grow beyond some 11-12 millimeter of size, and that's when I will check whether the patient's LH value is raised. If the LH value is raised, I need to suppress that, increase the dose of my stimulation, and secondly, along with that, I have to see the value of progesterone, because LH rises, it luteinizes the follicle, and I may get some progesterone which is popping out, and the endometrium will become inreceptive to my embryos.
Yeah.
So this is what would be my suspicion in this case.
Yes. This is another case which is showing profound increase in E2 value. So I think this is alarming sign to see for the ovarian hyperstimulation syndrome. So what is critical level for that?
Day 6, 3000 only is horrible, first of all. So no, obviously, this is very important. Kitty follicles select झालेले आहेत. So first of all, how many follicles around about in both the ovaries, they would give rise to such a high amount of estrogen. How many dominant along with how many recessive. This would be the calculation. And then whether to continue stimulation or hold on, tell the patient we shouldn't go ahead with this because there will be a great hemodynamic disturbance in your body. So it is better to take a decision of abandoning the cycle. Doesn't matter, you cancel one cycle. So that would be my decision. Obviously, we have done it in the past. 1 or 2 cycles only, but we got these values more than 12,000, and we absolutely restricted that patient from taking any type of further stimulation for ovulation or anything. That's not possible. So